Please.
Great. Oh, so thanks very much to the SOAS group for inviting me to speak here tonight. My name's John Browne, and I'm a professor of health services research at University College Cork. I'm also the senior editor of BMJ Quality and Safety, which is the world's leading academic journal on issues such as the optimal configuration of emergency care services. I've been researching reconfiguration for the last 10 years. I want to make it clear from the outset that I am speaking tonight about my understanding of the general evidence base about emergency department downgrades and not about the specific situation in Enniskillen, which I have not researched. I have 15 slides and I'll discuss my work. So next slide, please. So urgent and emergency care has been reconfigured to various degrees across the Republic of Ireland, but most of it happened between 2009 and 2013. These initiatives were done on a piecemeal regional basis rather than for the country as a whole. In 2 regions, this involved whole system integration, for example, bypass protocols for stroke, STEMI, which is a type of heart attack, and major trauma. But the largest initiative was the reduction from 39 public emergency departments to 29 emergency departments. So 10 emergency departments disappeared in the Republic. And obviously that happened of economic stress caused by the 2000s.
John, we've lost sound with you for some reason. Your microphone, is there an issue with your mic presently? We were hearing you fine there just till about 10 seconds ago.
Hear me now?
No, faint, very faint. Can't hear you now at all.
I'm not sure. You just can only hear me faintly, is it?
Just faintly now. We had lost you completely there for a while. Now we're hearing you faintly.
Right. Maybe if I just speak a little bit closer, is that any better?
That's better, yep. Thank you, John.
I'll just try and speak closer to the microphone here.
Right.
Okay, so maybe just next slide, please. So here you can see the current location of emergency departments in Ireland. And it's worth noting that there are still 9 in Dublin, a city of around 1.2 million people. If you could just...
We're back there. Very, very faint. We're hearing you very faintly now, John.
Okay. I'll put my mouth right next to the... I might as well turn off the video, actually, because there's no point in seeing me.
That's a good idea, I think.
Yeah. So how is the sound now?
Very good.
Okay, good. Well, it might just be my broadband. So... if you just click once there, please. Yeah, so these, the black dots show you the 10 emergency departments that were downgraded to local injury units, which are open on a limited basis, either 8 to 8 or 9 to 5. Next slide, please. So here you can see that reconfiguration was most extensive in the southern and midwestern regions of the country, where 6 smaller emergency departments were closed, largely affecting rural populations. Those regions, the Midwest, which is basically around Limerick, and the South, which is Kerry and Cork, are the regions which are suffering the worst at the moment from the trolley crisis. And the trolley crisis is notorious now in Limerick and is also chronic in Cork. And most people believe that this is as a result of the closing of smaller emergency departments in the region. Next slide, please. And unfortunately, the reconfiguration agenda is alive and well in Ireland, and there are plans to downgrade as many as 9 emergency departments. Here you can see the former head of our health service, Paul Reid, advocating for fewer emergency departments at the start of the general election in 2020. And understandably, a lot of that talk went quiet when the pandemic hit, and it became obvious how important these emergency departments were. Next slide, please. So this push to downgrade even more emergency departments is happening at a time when public healthcare services in Ireland, like the UK and Northern Ireland, are under extreme pressure. In the Republic, we have up to 1 million public patients on waiting lists and a chronic trolley problem in emergency departments. especially in the hub hospitals like Limerick and Cork for the reconfigured regions. So what you see in Limerick and Cork today is what you will see in Derry tomorrow. The situation has got so bad in the Limerick Regional Hospital that the public are sometimes advised not to attend. And one can only wonder what the residents of Clare and North Tipperary make of this, given that their emergency departments were taken away and centralised to Limerick. And this is all happening against the backdrop of rapid population growth. Our Central Statistics Office projects the population in Ireland may grow by as many as 2 million people by 2051. And this will be happening in all regions, not just Dublin. Over the next 10 years alone, there will be a need for inpatient public hospital services to increase by more than a third. Next slide, please. So that all brings me to the Siren research program, which I led over 10 years and was funded by the Irish Health Research Board. And the aim was basically to figure out what was the impact of all this reconfiguration. And it's a large mixed method study that produced 10 academic papers, and they're all summarized in that final paper, which was published in the Future Healthcare Journal in 2020. Next slide, please. So we interviewed 175 proposedly selected internal and external stakeholders across all regions in Ireland. The term internal stakeholder refers to doctors and managers who work in the HSE and who were involved to varying degrees in reconfiguration. External stakeholders involves a heterogeneous group of GPs, pre-hospital care providers like ambulance staff, civic groups opposed to reconfiguration, politicians and media members. And we also analysed the major Irish policy documents. And here are the main findings. First, we found, as we've heard earlier in the meeting, very little evidence of substantive engagement by planners with the public and other civic partners. So your experience is not uncommon. And this was one of the root causes of a prolonged period of conflict between health planners and campaigns to prevent hospital downgrades. So we have had all these campaigns in the south as well. Some of these were successful. So the hospital in Portlaoise, for example, still is open despite efforts to close it. And the hospital in Navan has been on the brink of being closed for years now. Others campaigns weren't as successful, and that's why we ended up with only one emergency department in the Midwest for 400,000 people. And when it came to the debate, you see internal and external stakeholders constructing their own lines of argument and to some extent arguing past each other, not with each other. So safety and efficiency were claims that were made by the internal stakeholders who also decried the role of local politicians and tried to frame the campaigns as being about parish pump, what they call parish pump politics and a misinformed public. External stakeholders emphasized access and the value of a fully functioning acute hospital to the life of the community, but also disputed the way that safety and efficiency were framed by internal stakeholders. At this point, I should point out that in the field of quality and safety, which is the field I work in, we all accept that there are numerous dimensions to quality, and access and equity are important dimensions of quality, and no single group has the right to say that one dimension of quality is more important than another. Next slide, please. So here are a list of questions which were brought up during the interviews, and I think are really important and show that people on the receiving end of reconfiguration have many legitimate concerns. Here's one very important one. So what you've heard a lot about at the meeting tonight is the 1% of emergency department patients who require blue light transfer and are at high risk of mortality. They're a tiny group when you look at the larger group of people who attend emergency departments. And the evidence base shows that reconfiguration is all about the 1%, but it has nothing to do with the 99%. For example, frail older people who may require repeat visits to emergency departments because of exacerbations of non-life-threatening underlying chronic conditions. And the evidence base is clear that smaller emergency departments are perfectly capable of providing high quality care to those populations. Secondly, why is the reaction to safety incidents at large and small emergency departments so different? To the extent that it almost feels as though planners want things to go wrong at smaller hospitals to confirm their prior beliefs. Next, why is the Jenga effect, Jenga here meaning the game, of ICU and acute surgery downgrade so binary, and why are there no compromise solutions? Here, I mean the way in which many functions of an acute hospital cannot be sustained, especially emergency departments, if there is no ICU or acute surgery team on site. There are other options for providing that kind of care to people other than having one single unit or team on site. And then, of course, what about the other harms of centralization, like extra traffics on the road and the damage to the environment, the economic damage to smaller towns, the extra travel costs that have to be borne by older people and people on low incomes, ED overcrowding at the larger hubs like out in Gelvin, and obviously the disruption to local care relationships. So by that, I mean relationships between the staff in, for example, Enniskillen and local primary care providers. And more importantly, the downgrade, the local community facilities like rehab facilities or nursing homes, which the staff in places like Enniskillen will be familiar with and may not be as familiar to people in Out Gelvin. And then finally, if efficiency is important, why do we still have 9 emergency departments in Dublin, all in close proximity to each other? What other agendas, for example, the preferences of training bodies, medical professionals and medical schools about where to work and where to live are hidden from view, but strongly influencing planners? Next slide, please. So I've only 4 or 5 more slides to go. So what we found when we actually looked at the impact of reconfiguration on mortality rates was, here you can see the overall trend in case fatality ratios. And if you take the break point here as being about 2008, now remember, when things are going down, because these are death rates, that's good news. So what you see is that in the period before reconfiguration, we had quite steep declines in mortality rates, which is good news. People were surviving these serious emergency conditions at higher rates. And then you suddenly see a break point around 2008. And since then, we have seen a much slower rate of decline in mortality. Next slide, please. And when you look at the regional results, you can see the case fatality ratios at regional level to see if the reconfigured regions had the expected improvement in survival compared to regions that did not reconfigure. Now remember, when reconfiguration is being sold to you, it's being sold as something that's going to make things better. It's not supposed to just be equivalent to the status quo. It's supposed to be better than the status quo. It's supposed to improve survival rates. And the y-axis depicts the annual percentage change in case fatality rates, and higher numbers indicate a worse trend. And as you can see, there's no obvious pattern. In fact, all 3 types of configuration are represented above and below the national average. The best performing region was the West, which had really only 1 emergency department downgrade, and still has 5 emergency departments in places like Sligo and Donegal and Galway and Mayo for a very rural area. The worst performing region was the Southeast, which underwent no reconfiguration, but neither the southern or Midwestern regions represented by the green dots stand out as overperformers. So Cork and Limerick have not experienced some dramatic improvement in case fatality rates as a result of having centralized all their care to 2 hospitals. And when I discussed these findings with one of the most senior people in our public health service, someone who was heavily involved in planning the reconfiguration program, they told me that these results support the case for configuration because it shows that mortality hadn't got any worse in Cork and Limerick. But when I said, I thought the whole point of reconfiguration was to increase survival because small hospitals like Enniskillen are supposed to be so dangerous, they said, no, it's got nothing to do with that, really. It's because nobody wants to work in these hospitals. And that opened my eyes to the way that research findings can be framed and weaponized in this field. Next slide, please. And here's another example of this problem, which I think is very pertinent to your situation, this time using research conducted by colleagues in the RCSI. And the study found that there was no difference in survival rates for emergency abdominal surgery between low, medium, and high volume hospitals in Ireland. And in fact, if you look at the last column, the survival rates are almost identical. But look at how this study was interpreted. So if you could just click once, please. Here's one of the authors of the paper, Ken Mealy, who works at the RCSI. And this is a direct quote from a newspaper interview where he says this study, which shows that low volume hospitals are just as good as high volume hospitals, shows that we need to reduce the number of hospitals. Now, I'm not going to say any more, but I don't think that that is a fair interpretation of the results. The results show that there is no correlation here between the size of a hospital or the size of a surgical team and outcome. So moving to finish up then, if we could just go to the next slide. So to summarize the research I've done, it's obviously a complicated, contested policy arena. The terms of engagement are not clear. When the terms of engagement are not clear in a situation like this, there's a real danger that people try and pull the expert card and they just tell you, well, listen, you don't really know what you're talking about. I'm a professor, I'm a doctor, just do what you're told, listen to the experts. But this isn't an area where the experts agree. This is a contested area. Evidence plays a confusing role, especially the volume outcome literature, and it's not clear what the rules of the game are, and the goalposts keep changing. There was no evidence in Ireland that reconfiguration improved outcomes. Now, the research is obviously not perfect to test this hypothesis, and lots of other moving parts are in play. But if someone comes to you and says, the evidence is clear, we have to do X, then I don't think that that is a correct way to interpret the evidence base. The mortality evidence does not point in one direction, and policy solutions are not obvious. And this is my final slide. So here's the things I've learned from the work I've done. So first of all, you have to understand, I think if you want to do some research in this area, that the evidence rarely maps perfectly to every context. So if someone comes to you and says, well, look at this research from England, from London, from America, from Australia, it's very unlikely it directly maps to Fermanagh. We need to accept multiple perspectives on purpose, success, and failure, and that involves proper consultation. Understand that all evidence is framed, and there is no perfect frame. There's no perfect answer to these problems. And realize that it's dangerous when powerful interests do all the framing, because they'll do it inevitably because of human nature, because of their own vested interests. And I do think we should make a sustained commitment to working on these complex questions. And then finally, the don'ts. Don't start with lazy stereotypes about urban always being superior to rural, or big always being superior to small. Don't let the tail wag the dog here. And here what I mean by that is don't focus only on the most severe patients or only on medical workforce preferences. Don't change the goalposts when the findings are annoying. Don't buy the hype about the success of top-down restructuring plans delivering economies of scale or avoidable admissions. Any gains you see are likely to be drowned out very quickly by population growth and population aging. And finally, don't overgeneralize your conclusions and dismiss the importance of place. Place is very important, and there are unique places on this island, like Fermanagh. Instead, you're better off treating each investigation as a case study. Okay, that's all. Thank you for listening.